Assalamualaikum. Hello everyone. Welcome to the today's CME. The CME series is proudly brought to you by the Selangor State Government through its Awareness on Mental Health Programme, or widely known as SEHAT Selangor. It is a collaboration with IIUM, International Islamic University, and Malaysian Psychiatrist Association, MPA. I am Dr. Nofaiza binti Muhammad Tauhid, the moderator for today's CME, entitled Enduring Psychosis in Primary Care. Before we get started, I would like to go over a few items. The session will be started with a 40 minutes lecture by the speaker. You will have the opportunity to submit text questions for today's presenter by typing your questions into the chat pane. You may send your questions at any time during the presentation, or if you like, you can also ask questions directly to the speakers towards the end of the presentation. We will collect these and address them at the end of the presentation. Ladies and gentlemen, psychosis is broadly defined as the presence of delusions and hallucinations. It can be acute or functional. We consider psychotic disorders to reside primarily in the domain of psychiatry, but primary care and other medical physicians almost always see these patients at some early point during their illness journey, and they can play a significant role in their care. By recognizing that your patient may have psychotic disorder or be in the process of developing one, early referral is possible by the primary care doctors. The duration of untreated psychosis is directly related to time to recovery. Hence, primary care doctors play a pivotal role in reducing the duration of untreated psychosis and modifying the long-term outcome. Also, primary care doctors can play a key role in co-managing with a psychiatrist, patients often very prominent with medical problems. Unfortunately, there are many barriers to early recognition of psychosis. The first one is lack of insight, which is perhaps the most frequent symptoms of psychotic disorders, often delays seeking care by the patient. So this is actually not the problem of the primary care doctors. But the second one, that is self-stigma and societal stigma associated with the diagnosis of a psychiatric disorder, particularly a psychotic disorder, are prominent and difficult obstacles. Once the diagnosis has been made by the primary care physicians or primary care doctors, so the patients might not want to come again to see their doctors. The third one is the customary separation of mental illness from general medicine, meaning to say, medical clinicians are often unfamiliar with psychotic disorders, not because it is not considered part of their domain. And finally, the substance use disorder is observed in 50% of patients presenting with early psychosis. This greatly impedes the diagnosis of a psychotic disorder because the psychotic symptoms are complicated by the substance use. Looking at all the complexity of diagnosing and managing psychosis in the primary care, today's CME will try to shed some light on this issue. And we are very fortunate to have with us an experienced psychiatrist, Dr. Muhammad Faiz bin Muhammad Tahir. He holds a medical degree from International Islamic University and completed his master's in psychiatry from University Kebangsaan Malaysia. Since 2014, Dr. Faiz has been working at the International Islamic University Malaysia Kuantan campus, Kuantan, as a lecturer and psychiatrist at the IIUM Medical Center and Hospital Tengku Ampuan Afzal, HDAA. He also attends to patients at the Quit Smoking Clinic, HDAA, where he manages the care of patients with nicotine addiction. For that, I would like to welcome Dr. Faiz to present his slides on the CME entitled Enduring Psychosis in Primary Care. Please welcome Dr. Faiz.
Thank you very much, Dr. Faiza. Bismillahirrahmanirrahim. Alhamdulillah Rabbil Alameen. Assalamualaikum warahmatullahi wabarakatuh. Assalamualaikum and a very good afternoon to everyone. I think we'll go straight to our business today. Dr. Faiza, have you received the PDF file?
Sorry?
The PDF file I sent through.
PDF file. Oh,
Could you please, I'm not sure I can't share it here. Can you please share on my behalf?
okay, hold on.
Okay. All right. So just a few disclaimers, I think. We're gonna have this session, I think around 30 minutes. I'll share with you a bit of what I know on psychosis and my experience treating patients with psychosis at the various settings, okay, in hospitals and also in private setting. And I prefer it to be chill, santai sikit. If you want to ask questions in English, also can. In Malay, also can. While we wait for the PDF to be screened, you can have the PDF later, no problem. I would like you to go to, if possible, go to menti.com, menti.com. You can go to menti.com. I'll just probably put it here, menti.com. And please insert the number. If you go on, let me just put on the chat. Menti.com. All right. And just go to just put in the number, which is 3409 2415. 3409 2415. Okay, let's put in the number. And hopefully you will get to the Menti. Just check. This won't take a while. Sekejap ya. Okay, 34092415. I just want to know what's on your mind right now. If you can share with me. Just share. It's anonymous, so you don't have to worry about anything. Can you scroll down, Dr. Faiza? Page 2. Okay, this is disclaimer while you're going through menti.com. This presentation is intended for educational purposes only and do not replace professional advice. So whatever that we share here is just for us to learn. It will be difficult to learn everything in this 30 minutes, but try to attend to your issues, your questions that you want to ask, so that it could help you to help patients who are enduring psychosis in the primary setting. Okay, statement of fact and opinions expressed are those of mine only, unless expressly stated to the contrary. These are not the opinion or position of IIUM, MPA, KKM, or other relevant bodies or agencies. Next slide, next page, please, Dr. Faiza. Yep. Okay, so the keywords here that we're probably going to see and discuss quickly is about holistic care plan, which is something that you want to develop and you want to update yourselves, and also the long-term psychotic conditions. We will see what these conditions are, and the last one is these are all in the primary care setting, because sometimes we are reading materials that are representative of tertiary setting, meaning patients who are admitted to the hospital and whatnot. Now we're going to see the challenges of how are we going to deliver care at the primary care setting. Next page, please. Okay, so this is the plan this afternoon. We're just going to have a quick survey, 5 minutes, what we're doing right now. The content delivery will be around 20 to 25 minutes. Short discussion around 20 to 25 minutes, depending on how we fare with the content delivery and questions. And also a quick survey at the end, and it's very short, just for 5 minutes. So I hope that we all can agree on that. Page 5, please. Okay, so you might want to go to this menti.com with this number. I'm just going to check there are any. Okay, good. I'm just going to read a few. I'll share later. What's on your mind right now is the need to move forward. Nothing, blank, worried, tired, stressed, hungry, food, sadness, noisy, regret, audit, work, psychosis, exhausted, and risperidone. Now that's interesting. Someone also said he wanted a new phone. He or she wanted a new phone. We're just going to give another 30 seconds before we go to the next question. All right. Take your time. I think just only 10 people also responded. Fifteen seconds. 5, 4, 3, 2, 1. Okay, stay on this one again. The last one came in with I think I read that. Never mind. Okay. Can you give your opinion? In your opinion, patients in Malaysia presenting with a history of psychosis are commonly treated and managed at the general practice or the health clinic? Could you just give your opinion? Strongly disagree, disagree, not sure, agree, and strongly agree. Okay, the 3 coming in. 2 agree, 2 disagree, 1 strongly disagree. Now disagree and agree is the same, 3 and 3. More seem to be disagreeing right now. Still more seem to be disagreeing. Now it's neck and neck. Macam lumba kuda pula kan. Okay, a little bit more. So right now we have 12 responses. Agree is 6, disagree is 5. 1 strongly disagree. Another 30 seconds. We have agree leading by 1. Disagrees 5. Strongly disagrees 1. So basically it's just neck and neck 6-6. 10 seconds. Agree 7 now. So again, the question is, in my opinion, patients in Malaysia presenting with a history of psychosis are commonly treated and managed at the general practice or health clinic. Okay, not in the tertiary center. Okay, 5 seconds. 4, 3, 2, 1. Thank you. We have 14 responses. 7 agreed, 6 disagreed, 1 strongly disagreed. Thank you very much. And last question just for this afternoon. GPs and healthcare providers at Klinik Kesihatan are comfortable in treating patients suffering from primary psychiatric disorders. GPs and HCPs at KKs are comfortable in treating patients suffering from primary psychiatric disorders. All right. So we have 4 who disagree. So 4 feel that they are not comfortable. 5 feel that they're not comfortable. 3 agree that they are comfortable. 6 disagree now. 7 disagree. 1 not sure. 8 disagree. Okay. You have 14 responses. That's a little bit more. The next 20 seconds. So right now we have 8 who disagree, meaning that the GPs and HCPs at KKs are not comfortable. 4 agree that they are comfortable. 1 strongly agree that they are comfortable. 2 are not sure. 1 strongly disagrees. Okay, so it's basically 9 who disagrees with this statement, and 5 kind of agree, and 2 are not sure. Thank you very much. Okay, we're going to go on to the next phase. All right. Can we have the next slide, the page number 6, please, Dr. Faiza? Okay, right. Can we just take a while to just read this case study? I'll read it for you and you can read it on your own as well. Case study, Wahid. He's a 20-year-old Malay male. He studies at a local college in Kuala Lumpur. He was brought in by his mother to the clinic as Wahid displayed an abnormal behavior at home, starting 4 weeks ago while on his semester break. His mother reported that he became easily irritable, spoke more than usual, and at a fast rate. And on top of that, had mood swings. At times, he was noted to be extremely happy, and recently he appeared to be very sad. The changes that his mother noticed throughout this episode was that Wahid appeared to be busy thinking and planning for the next college student election. Nothing to do with the coming election in our nation. He was confident that he could win a high post. He wanted to bring changes to the college. He would work late into the night, sleep for just a few hours, and later wake up early in the morning and resume his work. His mother was surprised to find that he'd be energetic the following day. Wahid also did not take meals regularly. He'd skip them altogether, giving the excuse, these great plans are important to be implemented. I can't afford to waste any time at all, not even a minute. Okay, so let that sink in. Probably right now I want you to think, what are the possible conditions or situation or diagnosis that Wahid might be suffering from? I'll give you around 15 seconds. Bipolar disorder. Thank you, Noeliana. All right. You can put in the chat, no worries. You can also put it anonymously anywhere else. Bipolar disorder, manic phase. Good, Nazmi. BD, bipolar disorder. Okay, thank you. BMD, right? Thank you so much. Right. Thank you. We can keep the answers coming in. Can we have page 7, please? Okay, so these are the common questions that we will probably ask. Demographic is very important. I know that some of you are saying that bipolar is a mood disorder. We're supposed to be talking about psychosis. Yes, good. I know some people might be asking that. We want to address that. Also, sometimes individuals with bipolar disorder, they also come in with psychotic experiences or psychotic symptoms, and we don't want to miss that. We'll elaborate that in a while later. The reason that I'm probably not choosing a straightforward case of schizophrenia for this discussion this afternoon, perhaps, is because that I've been asking about colleagues who are in the primary care, in primary care setting, and most of them would say that if they get a case of straightforward psychosis, in other words, schizophrenia, they would refer straight away. They won't be asking too many questions. They won't be giving any medications. They would just refer straight away because to them it's purely psychotic, and they'd rather have a tertiary care center dealing with these kind of cases, which is not wrong, which is fine, which is fine. But cases who have mood disorders and at the same time plus minus psychotic disorders, these are the cases that might be be managed for quite some time in the primary setting. Because in my experience, sometimes patients with bipolar disorder, they do come in a little bit late. Late is kind of like relative, but they come a little bit late, and there have been some significant changes in their life that has began to take an impact. So we need to address this matter. We need to treat it optimally, and we always need to liaise with our colleagues or specialists in the field. All right. So demographic background for Wahid is 20 years old, Malay male. Sometimes with psychosis, we want to rule out things like substance. Sometimes we miss on asking about substance misuse or substance abuse disorder. This is very important. And sometimes also in our current generation, we see that people who have grandiose ideas or very energetic, it's probably just part of their current way of life. We do see that sometimes. We do talk about ADHD, right? We do talk about borderline personality disorder. We do talk about a lot of things when it comes to mood disorders and also psychosis. So these are quite interesting areas to discuss, but I won't be discussing it in this afternoon. Number 2, you see that the statement was brought to his mother to the clinic as Wahid displayed an abnormal behavior at home starting 4 weeks ago while on his semester break. Now, the questions that I normally ask is who normally accompanies the patient? We want to know the dynamics. Is it the mom? Is it the dad? Is it the sister? Is it the uncle? Is it the grandmother? Whatnot, and what the dynamics are like? Because this would help in the long-term management of the patient. Dr. Faiza did mention early on about the stigma. So stigma is not just from ourselves, the healthcare practitioners, but also from the family members and also friends of the patient. We would also want to know what the associated symptoms are, accompanying the symptoms that the mother reported. Okay, and what is the duration of symptoms and illness? In psychiatry, it is very important for us to understand that how long these symptoms has persisted, and was there any break in between the symptoms, and how does it fluctuate over time? These are the things that would help us to find the most significant or the most important differential diagnosis. Statement number 3, his mother reported that he became easily irritable, spoke more than usual and at a fast rate, and on top of that had mood swings. Yes, it's very clearly that we see that this is symptoms of mania. Most of you pointed that out quite right. And of course, again, we want to know who the informant is, because sometimes we do have cases where the informant has no contact whatsoever with the patient or does not know the patient to a good degree, and sometimes the informant is actually making up stories or symptoms. So we want to be very aware of that. We also want to know what did the informant notice, because sometimes we want to know what else that the informant has noticed apart from the symptoms that the patient displays. This means that sometimes the backstory, for moms, usually they are aware about the behavior achievement at school. That is also important for us to understand the past history of the patient. And are these symptoms that is mentioned in statement 3 peculiar to any medical or psychiatric conditions? Sometimes that all of you have pointed out, most of you have pointed out that this is bipolar based on the symptoms, but sometimes it could be something else. In other words, it could be organic disorders, if you're not careful. All right, page 8, please. Now, number 4, the changes that his mother noticed throughout this episode was that Wahid appeared to be busy thinking and planning for the next student election. Okay, we want to ask more questions to know whether this is something of a psychopathology. He was confident that he could win a high post. We need to know more. Okay, in this section, we need to know more and to get symptoms of grandiosity, if we can, right? He wanted to bring changes to the college. It seems that this patient is really goal-directed in that sense, right? So these are clues that we should be looking for. Number 5, he would work late into the night, sleep for just a few hours, and later wake up early in the morning and resume his work. If we just stop here, I mean, we do that also once in a while, or maybe uh, maybe frequently we do that. We sleep late, we wake up early, we are energetic, but then energy level does differ from um, individual to individuals. All right, and that's why we need to know what other associated symptoms are present during this episode. So in this case, his mother was surprised to find that he would be energetic the following day. Maybe for most of us, we would feel knackered. We would not be able to do our work optimally because we're not in mania. But for individuals who have mania, they would have all these. Okay. And last but not least, he also did not take his meals regularly. He would skip them altogether, giving the excuse of these great plans are important to be implemented. I can't afford to waste any time at all, not even a minute. And if we were to actually see this patient in our primary setting, I see patients also in clinics um, where patients sometimes present the first episode like this, and you will be wondering whether this mania or it's just someone who is, having high ambitions and all that. We need to ask those kind of questions. And the most important question that I would ask would probably be among all would be, is this a significant change from his previous self to his current self? And the other one is his normal daily functioning affected? And function, we divide into 3: the personal function, the social function, and also the academic or occupational function. To me, these are the indicators which are important to determine whether this is just a normal variation of an individual, or actually this person is actually going through some form of psychiatric disorder or illness. These are the things that we would really want to ask and be sure of, right? Okay. And mind you, before we go on to the next slide, is that some patients do present with psychosis in the term of, we know that psychosis, there are several types. Okay. We have thought disorders, and also we have perceptual disorders. All right. Perceptual disorders would mean all the 5 senses: auditory, visual, sensation, and so on and so forth. And also the thought disorders, which is the thinking disorder. And some patients with bipolar disorder, they are to a certain degree delusional. Okay, and these are the things that we want to try to dig out, and we would want to intervene or treat immediately. Next slide, please. All right. So for those of you not familiar, this is DSM-5. Now they've come up with the TR, the text revision. All right, and we use this to make diagnosis, a mental disorder diagnosis. Some people use the ICD-11 now, but for us, mainly at universities, for me mainly, I use DSM-5 TR. And you can purchase this, or you can have PDFs of it. You can purchase it on the internet. All right. Okay. Next page, please. Okay, this is quickly, a criteria for bipolar disorder. Okay, and I think most of us quite aware of the symptoms. If not, you can have the PDF. You can go through it again. I think we're short of time. Can we just go on to the next page, please? Okay, some of you do ask about mania versus hypomania. So we can say that hypomania is to a lesser degree less severe than mania. That's just to say it in simple terms. And the other thing that differentiates hypomania and mania is the amount of days. For hypomania, it's 4 days, and mania would last. We would look into 1 week of symptoms. All right. Okay, and at least 40% of bipolar patients have a mixed episode at some point in their lives. Okay, meaning to say that they have manic symptoms or hypomanic symptoms, and at the same time they also have major depressive symptoms. Okay, so that's not unusual. Next slide, please. Page 12, please. Okay, this is very old study, but just to show how much of psychotic symptoms are being experienced by patients with bipolar disorder. So you do have grandiose delusions. They do have persecutory or paranoid delusions. They sometimes do have auditory hallucinations, although it's not as high as the grandiose delusions. And some do have Schneiderlin first-rank symptoms. All right. So this is the psychotic symptoms that may present to you at the primary setting. Okay. Next slide, please. Okay. Excuse me. Now, this slide is just to show the comparison between bipolar disorder with psychosis, because they are bipolar disorder without psychosis, with schizophrenia, and also to compare it with unipolar depression or major depressive disorder with psychosis. So the psychosis is the denominator here in that sense. You do see that bipolar disorder with psychosis and schizophrenia have positive symptoms, okay, meaning the delusions, the hallucinations. They are excited to a certain degree, and they do have paranoia or paranoid delusions in that sense. So it is almost similar. And that's why we would want to ask other questions to differentiate between bipolar disorder with psychosis and that from schizophrenia. Both bipolar disorder with psychosis and schizophrenia do have thought disturbances, but however, in terms of negative symptoms, in terms of mood symptoms, schizophrenia apparently seems to have more than bipolar disorder, which sometimes mimic a patient having MDD. And cognitive symptoms affected, clearly seen in schizophrenia. All right, okay. So that's why it's sometimes very tricky in the primary setting, where some of us would try to give benefit of the doubt, saying that this patient does seem to be a bit weird. The things that he says doesn't quite make sense, but when we do a cognitive test, he seems to be okay. So that would point towards more bipolar disorder rather than schizophrenia. All right. Page 14, please. We have a few more minutes before we go into the discussion. Now, just to recap, for some of us, positive symptoms versus negative symptoms. Positive symptoms are delusions, hallucinations, disorganized speech, disorganized behavior, and also agitation. And the negative symptoms, especially that seen in schizophrenia and also mood disorders of depression, is lack of interest and hedonia, difficulty in organizing, concentration difficulties, social isolation, lack of emotions, and lack of energy. But being in the real world setting, sometimes you do see some patients with bipolar going through the negative symptoms as well, although it's not that frequent. You see that. All right, page 15, please. Now, these are the types of psychotic disorders that I do agree seen in practice, in primary practice. Schizophrenia, I won't say most common, but we do see schizophrenia. Schizoaffective disorder, this is something which sometimes is very tricky for some. I won't mention on schizophreniform disorder. Delusional disorder, it's hard to see at the clinic because, they don't think they are unwell. They think they're well, they're delusional, so they don't really come for treatment or for evaluation. Sometimes who brings them are their family members. And you probably just see them once or twice and then they will go off, unless we are able to increase the rapport with these patients. I have probably with me 4 or 5 patients with delusional disorder, and you really need to have a good high level of therapeutic communication for them to actually maintain taking medications and working or doing the things, normal daily things in life, or else they would just be impaired in that sense. Brief psychotic disorder is quite also common, but normally they will come to the emergency department and straight away to the ward. That's my experience. Substance-induced disorder, again, it's quite a lot, especially with all these ATS, amphetamine type stimulants, all these things that everyone is taking. They do present to the emergency department with substance-induced psychotic disorder. Bipolar disorder is very common. We see that. Postpartum psychosis, another one, and also severe depression, which some of them would also have psychosis when severe enough. All right, next page, please. Now, this is differential diagnosis of new onset psychosis. See, for instance, if you were to see psychosis at your clinic, okay, at your center, we want to know whether this is primary or this is secondary. Secondary, this is the usual term that we use, is organic psychosis, organic related psychosis, which is toxic, dementia, anything related to medical illnesses, toxic drugs and medications. And the primary ones would be along the schizophrenia spectrum. What it means, the schizophrenic spectrum, is that from brief psychotic disorder to schizophreniform disorder to schizophrenia spectrum disorder, to schizophrenia disorder. This just, the symptoms are the same, the duration is different. Brief psychotic disorder is below 1 month of symptoms. 1 month to 6 months is schizophreniform, and 6 months above is schizophrenia. Technically, that's how we term it. And also other psychiatric illnesses as primary and new onset psychosis, such as we mentioned, bipolar disorder just now. Okay, page 17. Page is coming to an end. Okay, these are the psychotic disorders that I normally see, all right? And schizophrenia in terms of prevalence, okay, in non-institutionalized person means that people who are out there, doing their stuff, is around 0.33% to 0.75%, or easily said below 1%. And for bipolar disorder, the past year prevalence back in this is 2016, in females and males is respectively below 3%. You can see, you can refer to the National Institute of Mental Health, and the reference are as below. So you can see that bipolar disorder is of higher prevalence as compared to schizophrenia. Okay, next page, please. Okay, now at your clinic, I understand that we all rushing for time, and sometimes we would want to see patients quite fast because of all sorts of reasons. So this is a rapid mood screener. Okay, it has 6 questions. I'm just going to read it quickly. Question number 1, have there been at least 6 different periods of time, at least 2 weeks, when you felt deeply depressed? They're asking about depressive symptoms. Okay, did you have problems with depression before the age of 18? All right. Have you ever had to stop or change your antidepressant because it made you highly irritable or hyper? Have you ever had a period of at least 1 week during which you were more talkative than normal with thoughts racing in your head? Okay, this is more hypomanic or manic symptoms. Have you ever had a period of at least 1 week during which you felt any of the following: unusually happy, unusually outgoing, or unusually energetic? Again, manic symptoms. Have you ever had a period of at least 1 week during which you needed much less sleep than usual? Similar for the case of Wahid that we've been discussing early on. Okay, so this is one of the rapid mood screeners that you could do at your clinic. Next page, please. Okay, I also normally use back anxiety inventory, also back depression inventory, and all these are self-report questionnaires. It is available in both English and also in Bahasa Melayu, and I use it quite a lot to look at the anxiety symptoms, because sometimes bipolar, apart from coming with psychosis, they also have high anxiety symptoms. Next slide, please. Okay, these are the Malaysian clinical practice guidelines available. And you can see that the bipolar disorders in adults, it has been in 2014, and it's been 6 years now. I think they're working on the latest edition. I'm not sure when it will be out. And schizophrenia since 2009. Okay. Next. Thank you. We're coming to the end. When I'm treating patients with bipolar disorder and psychosis or any other psychotic disorders for that matter, we would like to look at the biological, psychological, sociological, and also spiritual dimension. This is very important because we do have patients we know that come in with saying that the psychotic experience that they're going through is something that from the spiritual dimension. You know, they have lack of insight to know or to agree that this might come from a biological dimension, meaning to say that the neurotransmitters are not doing their work properly in that sense. You know, it's just like diabetes, because the insulin is not working well, and therefore you have poor glucose control, and then you will get all these complications. So why couldn't it happen in the brain, where neurotransmitters in the brain are also not functioning properly for whatever reason that is? So we need to understand that the patient, although they would present their argument from a spiritual dimension, we would need to find ways to also present our argument or our hujah kita from a biological dimension, from a psychological dimension, from a sociological dimension. These are an important strategy to use in order to develop good rapport with the patient. I would say that. Page number 32, please. Okay, so when we're discussing bipolar disorder, it depends on which phase the patient is in. Okay, it could either be they present early on with acute mania, an acute phase, either acute mania or acute depression. So the management is going to be slightly different. And when the patient is on long-term treatment, meaning that we are stabilizing the patient, they can either be in remission because we have done a good job in treating the patient, and sometimes the patient might also have a relapse or a recurrence. Recurrence means more than 6 months away from the last remission. These are the things that when we're managing patients, we want to know which part or which phase that they are at. Okay, so we can discuss this further in the discussion section. Okay, next. Okay, I think this is one of the last slides. So when we are treating patients, when I'm treating patients, I would like to look from the biopsychosocial, spiritual point of view. From the biological point of view, of course, this is where the medications that we learn about comes in handy. We use antipsychotics, we use mood stabilizers, we use benzodiazepines as well. And from the psychological point of view, we have psychoeducation, which is a very, 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 very strong tool. CBT, IPSRT as well, and also family-focused therapy. So sociologically, we want to work with the patient in terms of its academics or work, and also with his community, and last but not least, spiritual. I'll give you an example in the case of Wahid. So if I were to ask you what kind of, if we confirm Wahid having bipolar disorder type 1 with psychosis, and he's in acute phase, so what kind of antipsychotics that we want to choose for him? Does he need a mood stabilizer? Does he need benzodiazepine? So all this would depend on the patient, they will depend on the family, they will depend on our comfort level of using certain medications. So these are the things that, and also the medications that are available to us in terms of availability and also cost. So these are the things that would determine what kind of biological treatment we would give to Wahid. Okay. Also psychological. I think psychoeducation, everybody can learn that, everybody can master that, with enough information, with enough skills, that shouldn't be a problem. CBT, of course, I personally, I don't do CBT for my patients because we have the services of psychologists, so that's good. Interpersonal social rhythm therapy, basically for Wahid, we will talk about sleep-wake cycle, we'll talk about communication with his family members and also friends and people at school. But this is, of course, not done in the acute state. It's done more in after the patient has reduced in terms of symptoms more than 50%. And also family-focused therapy. This is something which sometimes we forget to do or forget to include in our arsenal of management. Family does play a pivotal role in recovery of the patient. Also, in order that we reduce the risk of relapse, because we know that there are some family members who what we call as having high expressive emotions. I'll give you an example. Wahid's mom would say that, you don't take medication, later you become manic again, for instance, you know. Okay, thank you, Kim. I'll respond to you in a while. Okay. Or they would say that, if you don't take medication, they will go straight to the ward, psychiatric ward. You want to go there. So these are things that parents with high EE, and we need to actually address this, all right? And academics and work community. If the patient is academics, we need to liaise with the academic section. You know, we want to see whether he can be on MC, or he can be on leave, or he can defer his studies. And also if he's working, you know, people are working, whether they can go on MC and stuff like that, right? And spiritually, it depends, you know, on the patient's belief. This is where we would advise them to meet with spiritual people, you know, orang yang bidang itulah. We'll just refer them to that. I don't normally or personally do all the spiritual work because it is not under my purview. All right. Okay. And 24, before I answer the questions, I think we have a bit more time. Okay. All right, so you can go to menti.com 32928665 and you can ask questions, comments, and suggestions there. I'll read some of those here. Thank you very much for those. This is from Kim. Hi, Dr. Faiz, can we initiate antipsychotic and follow-up schizophrenia patient in primary care after rule organic causes, or we do need to refer psychiatry for diagnosis confirmation before treatment? All right. Okay, thank you for the question. Personally, I would say that we would want to refer to tertiary care because there is a registry, okay? And in practice, as far as we've done in hospitals, that we do fill up the registry and we do treat the patient initially before we transfer them for primary care, because sometimes the medications that are available in the primary setting might not be optimal for the patient, you know. But if the primary care is somewhere in, you know, interior areas, then I guess it's better to treat there. But if, say for instance, my clinic is just next to a tertiary center, you know, I would probably refer to them depending on how fast the waktu menunggu, atau what do you call that, waiting period to be seen by the psychiatric department is. Because sometimes I understand it's 1 month, sometimes it's 2 months, it's too long. So yes, I think you can start treating the patient and continue to monitor him or her before they get that tertiary review. That's my opinion. Kim, thank you very much. Of course, I would like to answer more lengthy, but that's just a general idea. Okay. From Kabilan, thank you for the question. Good afternoon, doctor. I have a question. When a patient comes with symptoms of schizophrenia, stable, fulfilling the SM5 criteria, maybe after 2 or 3 visits of seeing the patient, after complete clinical evaluation, organic causes and substance abuse rule out. Thank you very much. And I would diagnose this patient as schizophrenia and subsequently put him on oral risperidone. My question is, do all patients newly diagnosed with psychotic disorders need psychiatric input to establish or reaffirm the diagnosis, as we could be dealing with probably schizoaffective disorder, schizophreniform, or delusion disorder? If not, what are the cases that needed second opinion from a psychiatrist, and what are the type of psychotic disorders that could be managed entirely under primary care setting? Thank you very much. Very good question again. This is how I see it. This is my opinion alone. In an ideal situation, yes, you would agree that we want the specialist to see and confirm all these cases in an ideal situation. But we are never in an ideal situation. We are in a situation where we lack human resource, we lack of time, we lack of financial support. And my take on this question is that as a primary at a person at the primary care setting, that they do their best in evaluating the patient, in treating the patient, in monitoring the patient, and ensuring that the patient is achieving optimally in terms of occupational or academic or in normal daily life. And if there is evidence saying that they are not achieving that optimally, then we must look into our management strategy. And this is where the specialist input would be very, very um, um, valuable in that sense. And I agree with you. Sometimes we're dealing patients who have schizoaffective disorder. Um, I wouldn't say much of schizophrenic form disorder because it's just uh, uh, a disorder which is between 1 month and 6 months. You know, between brief psychotic disorder and schizophrenia, they still have the symptoms. It's just, to me, it's just a technical term. And yes, for patients who have delusional disorder, sometimes we think that the medication, um, in this case, you're giving him or her oral, if I'm not mistaken, did you give risperidone? Yes. There are other treatment strategies that might be good for the patient. In short, we will do the best that we can for the patient within our our capability, within our resources, and at any point of time that we can refer them to a tertiary center while waiting for that, while waiting for them to be reviewed, you can always continue to treat them and keep track of what happens to them. Speaking of medication, there are patients that when we start on antipsychotic 1, they might not be suitable to it, so we need to change to antipsychotic 2 or 3 and 4, you know, and depending on what do we have in our setting. So that's a question. I'm not sure what you have in your setting. I understand that there would be risperidone, there would be haloperidol, of course, but that's first generation. There would be quetiapine. I think quetiapine now with generics, they're doing quite good. But you know, we don't have much of the newer drugs. Although I don't use so much of newer drugs, I use mainly, if you say schizophrenia, yes, I do use risperidone. I do use olanzapine, and I do use Seroquel for that matter, and also aripiprazole. I think aripiprazole is it's not the best, but you know, in certain patients it does the work. You would get the hang of it when you see a lot of patients, because when we start medications, of course, we will look at the desired effects and we will look at the side effects. And patients mostly they look at the side effects. You know, is this going to make me fat? Is this going to make me sedated? Is this going to make me have metabolic syndrome after so many years? You know, these kind of things that they ask, and we need to tailor to their needs in that sense. So yeah, it would be good to discuss with a specialist in that area, because I understand that in primary setting you have to deal with a lot of other things such as hypertension, such as diabetes, all other things. So it might take up your time, so it's always good to discuss. I like the question, both of the questions. Thank you very much. Any more questions that we have, Dr. Faiza? Thank you, Gabilan.
Any more questions from the members?
Any other area that you probably need to I'm sure that we can't cover a lot of things in just 1 hour, but at least we could try to guide each other into what the patient needs. I mean, we're doing this for the patients. I think that's lovely, and we'll see what we could do. I'm just going to check on Menti if there's any questions that are shared.
Dr. Fai, I have another question.
Please.
One of the important aspects of managing psychiatric patients is the psychotherapy. Not psychotherapy, I mean to get them back to the community.
Okay, all right, okay.
Rehabilitation, that's the word. Rehabilitation. So in the sense of primary care, how can you integrate, how can they integrate the rehabilitation rather than just the psychomedication? How to integrate in these patients?
Okay, this very good question, Faizam. Very challenging if you ask me, depending on which area that person lives in and what kind of community that they have. Because now, apart from just educating the patient, apart from just educating the family members, now we would have to also educate the community as well. As far as my experience is concerned, at the moment, the community, the level of acceptance by the community can be improved further. It's not the best at the moment, because we do know that awareness of mental health, especially among our communities, is very, very low generally. So when we want, for instance, we want this person who has schizophrenia, who is on treatment, who is stable, to go and get a job and maintain on that job without the support of his employer, without the support of his colleagues or working partners, it's going to be very, very challenging. You know, they are going to relapse, they are going to get upset, and they might, you know, be worse, from there on, because they see that they don't have any support. And mind you that a significant number of suicide in patients with schizophrenia occurs when they are stable, when they are treated, and when they gain insight of what has happened to them. You know, one day they will just wake up and say that I have a disease, or I have a disorder, which is lifelong, which is incurable. You can't control the symptoms, but it's incurable, it's irreversible, and they will feel very, very, you know, depressed and very suicidal, and that's when most of the suicide would actually occur, you know, as opposed to when the patient is actually in a psychotic state. All right, so these are the things that we might want to be very, very aware of, the dynamics happening in the patient and also the family members, right? So in terms of rehabilitation back to the community, it's a very huge challenge. There are a lot of NGOs that are assisting patients, but you know, in my opinion, assisting patients with psychotic disorder is much more challenging than assisting patients with just probably anxiety disorder also, or just mood disorder. That's my take on it. Thank you. Any other things that we could probably discuss?
Any other question?
Okay, you can go to, if you're shy, you can go to menti.com. Let me just put it on the chat. You can just ask questions, don't worry.
Okay, Dr.
Yeah.
Faiz.
Yes.
Usually we refer to the tertiary center, especially the psychiatric center, according to the severity of the illness and also the availability of the medications. But in terms of the time that need to be spent on the patients, in some kind of cases, you need to spend long time just to listen to the stories. So does this warrant for referral to the tertiary center?
I would say so in that sense, you know, but you know, until we agree between the tertiary center and the primary setting, what we could offer to the patient, I think that would be best. For instance, we understand that in primary setting that the time is of constraint, you know, and also in tertiary center, it depends on which center that you're referring to. Sometimes you don't have enough personnel to actually look into thorough detail of the patient. So everybody is actually struggling to give the patient an optimal form of management. So therefore, what I believe and what I do in my practice is basically I empower the patients, I empower the family members to know, to read on, to understand what is it about psychosis, schizophrenia, bipolar, what is it, and ask questions to the people giving the treatment. They can ask me, they can ask anybody at the primary care setting, and they will need to find the support in terms of that medical arm, you know, because we do know that a lot of our patients would rather find support in other arms, ARMS, and other arms such as spiritual arm, such as product, young, you know, anything arm, you know, they will go through there because they get the support. They ask questions, they get answers. The quality of the answer is questionable, but in my opinion, because we are not engaging our patients, and therefore they will go to somewhere which are engaging them, which are giving them some kind of response, and it's not always the right response. So it is not just on us, tertiary care doctors, primary care doctors, to be treating the patients, but also the patients need to understand, the family member needs to understand that they need to be empowered. They need to know that they need to take care of themselves as well. I've moved away from paternalistic kind of care, you know, kena makan ubat ni, you have to eat this, if not then you kaki potong, whatever it is, or not nanti you akan masuk ward. You know, I don't do that anymore. I don't use that kind of strategy technique anymore. But what we do is that we want to empower them. You know, we want to be their partners in their health. And I might just say this out loud, that I use a lot of techniques of motivation interviewing. You know, there are certain strategies. Meaning to say that if the patient does not want to take medication, it is not their fault. I would say that we have not discussed this thoroughly with the patient or family members, and that is why they take the easy way out. You know, I don't understand anything, so I'm not going to take my medications. Full stop. It's as easy as that. But what we can do is that what is it about your illness or disorder that you want to know? What are the challenges of taking your medications right now? And most of them would say that, you know, it's the side effects, it's the cost, it's this and that, which is true, you know, because sometimes when we are in the ward, I used to work in the ward, you know, in various disciplines, we just give them medication and say, okay, you balik rumah, you makan ini 3 kali sehari, full stop. That's all there is to it. You know, there's nothing about, if you have problems taking these medications, let's discuss, you know. And of course, I agree, there is little amount of time for us to do so. And that is why it is important for us to train other people, not just doctors, but other people to also be able to deliver this form of psychoeducation. You know, that's my take on it. Thank you for the question, Dr. Faiza. I'll read a question from KKIA Muka. In my previous posting, I'm happy to be able to work with the Mentari Clinic team in Butterworth, Penang, but may I suggest that to increase skills of MOs in primary care, perhaps MOs can rotate to attach at Mentari as well in Malaysia. Yes, I think that's a very good suggestion, and I'm not sure how you're going to go about, but I think you can write into the people in Mentari, you can write into the tertiary hospitals which run the Mentari under their care. Very good suggestion. Nani Shoaib. Assalam doctor, what do you think about cognitive rehabilitation in schizophrenia patient? Is it really effective to help them? Thank you, Nani, for the question. This is my opinion. You know, I would say that patients with schizophrenia are on different severities. You know, the severities differ. The components, the domains that affect it differ. If I can just recap, there are 5 components or domains of schizophrenia: the positive symptoms, the negative symptoms, the cognitive symptoms, the mood symptoms, and also the aggressive symptoms or domains. So not all patients with schizophrenia have equal amount of impairment in these domains. Some are having more of positive symptoms, some are more having negative symptoms, some more aggressive. So, you know, when we talk about a specific rehab treatment or cognitive rehab, we want to see what is the overall functioning of that patient, how long the patient has been suffering from schizophrenia, what kind of medication that he or he is on, and what kind of support that they have in terms of long-term prognosis that we want to calculate again. So these are all the things that we need to take into account, and then only we could see whether this form of cognitive rehabilitation is going to be effective to help that individual patient. You know, as a blanket, to me, as a blanket rule, everybody has access to medication and treatment. They can go through that treatment, they can go through that rehabilitation and whatnot, but you know that not everybody is going to be benefiting from it optimally. So it is our job to actually evaluate all these patients and continue to see their progress when they are under that kind of treatment strategy, and to decide at the end of the day, I think you should continue this, or I think, you know, this might not be as effective as we thought that it would be. Okay, but generally, cognitive rehabilitation is good in patients with schizophrenia, but from an individual point of view, that's going to be a total question altogether. All right. Okay. Any more questions? Thank you so much.
Any more questions? Or else I will end this session soon.
I hope that helps everyone with needing to treat patients with psychosis. We do apologize for the short 1 hour because, you know, it's a huge topic and there are a lot of challenges to overcome. That's the least that we could do. Could everybody just go to menti.com 32928665 and just go to the last question, which is how confident you are in treating. Just give me an idea of, you know, are you more confident or not? Okay. Can go to that. Just a one last before we end. Is that possible? Okay, just one last from all of you. 32928665. You two have agreed. Thank you very much. So that we could probably give more in the future. If not 1 hour, we could probably give a half a day or 1 day course. Not sure, fair enough. Thank you for the honesty. A little bit more. Okay, 3 has agreed. I give 30 seconds before we end. There are actually a lot of material on the net, on the internet that that discuss this topic, and I find it very, very relevant. And I hope that one day we could sit down and really discuss what we could do at our setting, you at your primary setting, me at my tertiary setting. Sometimes I do also a private practice, so it kind of like becomes relevant to me as well, because in private practice sometimes you don't have the medications that you want, and also cost is a factor where insurance does not cover most patients with mental disorders. So it is a real challenge. So I hope that we could meet in the future. You can have my email, Dr. Faiza. Can you just show the last? Yeah, so that's my email, faiztahir.my@gmail.com. You can have the PDF. Yep. Yes, I do agree, KKIA Muka. We ought to do a lot of open learning course in psychiatry so that we can come in at our own time. I do agree with that strongly. I do. Thank you so much for that. So I guess this is the last from me, and I'll share the outcome later, or you can email me and I'll give you the outcome of our discussion and Mentimeter. And thank you very much. Back to you, Dr. Faiza.
Okay, one last advice, doctor. Since
Yes.
we have figured out a lot of challenges and a lot of limitations in the
Yes.
primary care emergent psychosis, so what's your last
Yes.
What's your last advice to the primary
Oh, my
care
last advice. Sorry, I missed the
managing
question.
psychosis?
I won't.
Especially the limitation of
Yeah,
time.
I won't say advice. I would just say that my thoughts are that I want to share with all of you is that we do the best that we can with whatever that we have to ensure that other people are able to go through life optimally in the most comfortable manner as possible, because we can't save everybody. We can't save everybody, but know our strength, know other people punya strength, know our resources, and that's where we can plan to make this place a better world. That's all I can say. So back to you, Dr. Faiza.
Yeah, that applies to everything in life as well.
Yeah.
Thank you very much, Dr. Faiz, for the very enlightening session. And I hope everyone gains a lot of benefits from this session. And we will have another session this Friday. You can refer to your PDF file soon. And for that, thank you again, Dr. Faiz. And
Thank you very much. Thank you, everyone.
Assalamualaikum.
Waalaikumsalam warahmatullahi wabarakatuh. Bye-bye. Take care.